Okay, we're all good. Can you hear me okay, Dr. Kato?
Yeah,
Yay. Okay, finally. It's 12:01, still not too bad. Welcome everybody to our CPPI seminar from September. Today we have a very esteemed guest and speaker with us, Dr. Dima Qato. Dr. Dima Qato is a pharmacist and pharmacoepidemiologist and is currently at the University of South California as a Hygeia Centennial Chair and Associate Professor in the Titus Family Department of Clinical Pharmacy at the Alfred Mann School of Pharmacy and Pharmaceutical Sciences. She's also director of the program on medicines and public health. She's been appointed as a senior scholar with the Leonard Schaefer Center for Health Policy and Economics, and she also served as National Academy of Medicine Pharmacy Fellow for 2018 through 2020. Dr. Qato received her Pharm.D from UIC, an MPH from Johns Hopkins School of Public Health, and a Ph.D. in Public Health from the University of Illinois School of Public Health. Dr. Qato utilizes population-based methods to better understand the underlying mechanisms responsible for the use, underuse, and unsafe use of medications, how these patterns may influence health outcomes and health disparities, and what can be done from a community and policy perspectives to address these growing public health problems. As you will see, there's a breadth of research, especially in pharmacy deserts, which have contributed important insights to policymakers and to the role of pharmacies in public health and health disparities. And Dr. Kato's goal is really to promote public accountability to better ensure access to and safe use of medications at the national, state, and local levels. So without further ado, I would love to welcome you. Thank you so much for accepting to present here today, and we look forward to listening to your talk.
great. Well, thank you for inviting me. I look forward to, the discussion. It looks like question and answer is later, and I'll kind of spend the first 30 or 40 minutes kind of presenting on structural racism and disparities in access to medications in the United States. And this really kind of is central to the work that I do around the role of policy in pharmacy access and disparities in pharmacy access, and how that contributes to persistent and often worsening disparities in medication adherence and medication use. Some disclosures. I'll start by kind of level setting and sharing what I found to be a useful depiction of understanding structural racism, especially in the context of what most are familiar with, the social determinants of health. And, the understanding of structural racism as a fundamental cause of health disparities, including the social determinants of health, is really key because structural racism really is rooted in policies and practices that may contribute to social determinants like poverty and segregation, but there's also policies that are implemented by federal and state actors that could worsen disparities, whether it's vis-a-vis these social determinants of health or independent of them. And that's really where I think, and what others have really kind of argued, it's important to really address the underlying cause or the fundamental cause of the social determinants of health. And that's really the focus of my work. And that's why I focus a lot on policy when I talk about pharmacy access and disparities in medication use. And to do that, I try to incorporate my understanding of structural racism as it applies to access to medications, given what we know about the process of medication use and what we know about how the US is structured, especially around residential segregation, but also specific policies. And in this kind of depiction, I focus on Medicare Part D policies specifically, because that is a big part of the work that I'm currently doing on pharmacy closures and the role of Part D policies on contributing to worsening closures as well as disparities. So, you have these policies. So in Medicare could be exclusionary preferred networks, low reimbursement rates to some pharmacies and not others, kind of insufficient or inadequate pharmacy access standards that are applied to some plans, and others are exempt. And these policies, I argue, as well as other policies, contribute to these because of structural racism, whether it's worsening or the effects of segregation on outcomes or access, or contributing to new barriers or worsening barriers in the communities that are largely Black or Latinx or Indigenous. And in terms of the Med-D policies, they could contribute to more closures in these neighborhoods, worsen geographic access to pharmacies or pharmacy deserts, and therefore delay or prevent people from getting the medications they need at the pharmacy, and therefore they're less adherent, independent of other community level factors. So whether it's poverty, transit access, or type of plan, copayment, right? It's that these policies make it harder for certain communities, and I argue because of structural racism, makes it harder for Black or Hispanic or Latinx populations to access their medications, and sometimes even make it easier for more advantaged populations, specifically white populations, to access their medications. And it's policies, whether it's federal policies through the Medicare Part D program or state policies that contribute to declines in geographic access or more closures. A lot of these problems we're seeing are related to public policies that could be modified and prevent some of the problems we're seeing in the neighborhoods that really need. We're trying to improve access to medications and improve access to pharmacies to do that. And it's hard to do that when there's policies in place that are kind of at the system level that make it really hard for pharmacies to stay operational, to stock certain medications, to implement certain policies. So I'll be going through some of that today. Specifically, at the federal level, I'll focus on Medicare Part D, but there's other examples of other policies that I've worked on and others, including the federal retail pharmacy program for COVID-19 vaccination, which, for those who are not familiar with it, started off partnering with retail chains. And we know that from our work that retail chains like your Walgreens and CVS's are less prevalent in communities of color than independent stores, and less prevalent in rural areas across the US. So by design, right, this is a federal policy, it could contribute to worsening COVID vaccination rates, increases in COVID-related mortality, right? Which we know was persistent, and even when the vaccination was available, and then the Dobbs decision 340B. And at the state level, I think this is really important because pharmacy practice is largely governed and subject to regulations and policies at the state level. So I'll be kind of going through some examples of pharmacist prescribing policies. So states that permitted pharmacists or allowed pharmacists to prescribe or furnish or medications without an individual prescription from a physician or other primary care providers. So, and to do that, the reason why I focus on policies is because they're really the causes that could be potentially reformed to better address the adverse consequences of structural racism and its effects on persistent disparities, specifically in accessing medications. So this is the first kind of paper that we published over 10 years ago now that really highlighted, I think, for the first time, the role of pharmacy access when discussing disparities in medication use. And we focused on Chicago because I was in Chicago, but also because Chicago is one of the most segregated cities in the country, that's comprised of neighborhoods with very unique racial demographics, ethnic demographics, and income segregation. And since then, it's, we've just proven, and others have really confirmed our findings as well in different settings. But for us, we also confirmed that what we found in Chicago in terms of pharmacy deserts, so fewer neighborhoods having access to a nearby pharmacy in Black and Latinx neighborhoods than white or even diverse neighborhoods across U.S. cities. And this persisted over an 8-year period and across these different cities. The magnitude kind of varied, but this is just some of the maps, and this is all published in Health Affairs for those that are interested. And then, what became apparent is that you can't really talk about pharmacy access, at least, when I first published this work, because pharmacy closures started happening in our communities. I mean, it became apparent. And so we started looking at, okay, are pharmacies closing, and is that contributing to a decline in the number of pharmacies in the US? This is kind of a national study that we did. And we found, yeah, pharmacies are closing. This is between 2019 and 2015, which is when we looked at pharmacy deserts across US cities. But there was still kind of a growth. There were still more pharmacies. There was retail pharmacies across the country, despite these closures. So there were pharmacies opening that exceeded in number the number of pharmacies that closed. And this is, at the national level. But when we look at specific neighborhoods based on their racial ethnic composition across, these 30 cities that we know are more likely to have pharmacy deserts in Black and Latinx neighborhoods, it's actually those same neighborhoods, at least, that are having their nearest pharmacy closed. So even if most people live more than a mile from their nearest pharmacy, you see that pharmacy closed more often than you see pharmacies in other neighborhoods close, which could worsen pharmacy deserts or pharmacy access in the neighborhoods that really need pharmacy access to be maintained or even improve. So without even knowing kind of at the policies that contribute to that, you kind of described, right? I mean, that was our goal, that over time, this is a persistent problem and it's getting worse in Black and Latinx neighborhoods, right? So structural racism through residential segregation, because there are predominantly Black and predominantly Latinx neighborhoods. There are predominantly white neighborhoods because the US is so segregated, especially in urban areas, especially in large cities. So we see that, pharmacy closures are happening more in these neighborhoods, including neighborhoods that are pharmacy deserts. And since then, especially in the last several years, every week you see kind of a news story pop out, more pharmacies are closing. This pharmacy chain is bankrupt, or it was acquired by a larger chain. And more recently, Walgreens goes private. CVS is closing so many stores every year, right? So it's a problem that's just getting worse. But what's important, and policymakers are aware of it. I think it's fair to say that 15 years ago or even 10 years ago, they weren't, even though it was happening since Part-D was first implemented in 2006 especially in some of the more rural areas. But it didn't really get recognition from federal and state policymakers until, I would say, the last 10 years. And so for different, whether it's through CMS or Medicaid, or recently it's PBM reform, right? But the problem of pharmacy closures continues, and it's getting worse, and it's important to address it. Whether it's through changes in state policy or federal, including improving PBM accountability for some of the practices that have been cited as problematic. So, okay, all of this matters. Why? one of the first questions I was asked when we did our pharmacy desert work and also our pharmacy closure work when I was in Chicago was, okay, does it even matter? Like, yeah, it's a problem, but does it impact, like, there's still a lot of pharmacies. People could just drive, another mile or two, you know. And so we got an IH grant to study that question. Do pharmacy closures contribute to declines in medication adherence among older adults? And what we found was, yes, they do, using an interrupted time series study design with a control group. And the effect is persistent. So people even are most people just discontinue taking their medications. And at least for our period of 12 months post-closure. And we see this even among people that were fully adherent at baseline, right? So people that overcame all the other barriers we know affect medication adherence. Once the pharmacy they used to fill kind of the medications, these key essential medications for cardiovascular health, if that pharmacy closes, they're immediately less likely to fill their medication, and that problem kind of persists over a 12-month period. So fast forward kind of a couple of years, this is published earlier, I think late last year, maybe earlier this year, but we found that even after our first study, right, more pharmacies are closing now. It was 1 in 8 between 2009 and 2015, but since 2010, it's 1 in 3 pharmacies have closed. And for the first time in over, 15, almost 20 years, right, we see a net decline in the number of pharmacies. So the rate of pharmacy closures doubled, and the rate of pharmacies opening really didn't increase that much. So you see kind of a decline, a steady decline that persists after 2018, so starting in 2019. And this affects kind of the entire country in different ways. The closure rates are higher in some counties than others. And there are some counties that don't even, I think it's over 400, that don't even have a pharmacy. So these closure rates are among counties that have pharmacies, where a third of them experienced a decline, a net decline in the number of pharmacies serving their neighborhoods. And as we found before, these closures are more likely to be independents, more likely to happen in Black and Latinx neighborhoods. So 37.5% of pharmacies located in predominantly Black neighborhoods closed, compared to just 27.7% of pharmacies located in white neighborhoods. And also, closures are more common in low-income neighborhoods, disproportionately publicly insured neighborhoods, and those that have a higher uninsured rate. But what was interesting in this study is that, after accounting for pharmacy type, urbanicity, uninsured, poverty level, and private to public insurance ratio, predominant race ethnicity persisted. So regardless of all these other factors, Black neighborhoods were more likely, pharmacies serving Black neighborhoods were more likely to close than all other neighborhoods. To look at, because we know and we found here that independent pharmacies are more likely to serve pharmacy desert neighborhoods or low-income neighborhoods, Black or Latinx neighborhoods, all the neighborhoods that we know are disproportionately affected by closures, we stratified our analysis and we asked the question, are independent pharmacies more likely to close across all these? So even in Black neighborhoods, are they more likely to close? And we found yes. So regardless of the neighborhood, independent pharmacies are more likely to close. And these are the neighborhoods that are more likely to serve, right? So these are markets that independents often target because they are less profitable. They're largely publicly insured or low-income populations. And uh, even, and they're more likely to serve them, yet they're also more likely to close given system, and they're forced to close. So the difference between independents and chains, so I often discuss them separately, is that independent pharmacies are often forced to close, right? You don't see, headlines, independent pharmacy plans to close 10 farm, right? They're forced to close. They have one or two stores and they have to close because they're not profitable. Chain pharmacies make decisions on closures, at least when they're not, unless they go bankrupt or they're acquired. But regardless, parent organizations for chains decide which pharmacies they're going to close among the thousands that they own. And they're usually in these underserved pharmacy desert neighborhoods. But what I think is the most interesting is that pharmacies, for independent pharmacies that are critical access, which we define as the only pharmacy in a zip code, they're more likely to close if they're independent, but they're often independent stores. But I think what we found was in this, and the table is not in this, I don't have it here in this exhibit, but it's our exhibit 2. For independent pharmacies, it doesn't really matter, they're less likely to close. Actually, you see it here, right? You see 30% closure rate for critical access pharmacies if you're an independent pharmacy. Whereas if you're a independent pharmacy in a neighborhood that has more than 2 pharmacies, it's 40%. So they're less likely to close in neighborhoods that only have an independent. So they're more likely to kind of stay as much as they can. They still have a higher closure rate than chains at 22.5%. But for chains, it doesn't really matter. The pharmacy kind of competition locally, they're just kind of making these decisions independent of how many pharmacies are in the neighborhood. They're looking at other factors, right? Including the private to public insurance ratio, how many people are privately insured, how many are publicly insured, and so on. Another important policy that we've considered is Part D's preferred networks, because they're growing. They account for about at least 75% of all Part D plans. So preferred networks, for those who are not familiar, incentivize individuals or patients with a Part D plan to use specific pharmacies through a preferred network, right? And the way they do that is they pay a lower copay. So if you have a preferred pharmacy network, you have a preferred pharmacy. And if you go and fill your medications at a preferred pharmacy, your copay is less than if you go to another in-network pharmacy that's not preferred. And obviously you can't go to out-of-network pharmacies, or you'll have to pay the entire cost of the medication out of pocket. And what we found here is that pharmacies located, again, right, this is a policy. Part D is deciding we are agreeing to plans that have certain networks and include certain pharmacies and exclude others from the networks. And what we found was the pharmacies located, as expected, in Black and Latinx neighborhoods, which are disproportionately independent stores, are more likely to be out of network and non-preferred for Part D plans. Right, so 18.5, 13.3, 4.7, 5.5, right? And then compared to 11.1 and 3.5. And even in those neighborhoods, you see more pharmacies in Black neighborhoods that have less than 50% of the plans that serve that neighborhood are preferred. Whereas in white neighborhoods, 45% of pharmacies participate as preferred for greater than 50% of plans. And then we asked the question, well, is preferred pharmacy status, so whether a pharmacy is preferred for the majority of plans, for a minority of plans, or is non-preferred across the board, but is a network, or if it's out of network, is that associated with closures? And what we found was, yes, actually, there's a pretty gradient effect. So pharmacies that are non-preferred for all Part D plans serving their area, which is usually a county or state or a region. And some of the plans are, it's national, but it's predefined. You see that it goes from 1.7 for pharmacies that are preferred for less than 50% of plans. So they're, 1.7 times more likely to close than pharmacies where they're preferred for the majority or greater than 50% of plans. And that goes up to 3.14 and 4.53. So non-preferred out-of-network pharmacies are 3 to almost 5 times more likely to close than any other pharmacy, especially those pharmacies that are preferred for greater than 50% of plans. And we know that Black and Latinx neighborhoods have fewer pharmacies that are preferred for greater than 50% of plans. So this is a kind of a more clear example of that could be modifiable, right? That contributes to closures that disproportionately affect Black and Latinx neighborhoods and beneficiaries, and therefore these persistent medication adherence disparities we've observed for decades could be related to a Part D policy that is kind of changing. Pharmacy networks are kind of, at least in the last year, have been declining, but not for reasons related to disparities. It's more for other kind of PBM related reasons. But it's a problem, and it's easy to overlook, and it's modifiable if we modify policies for Part D, where they need to kind of expand networks if they're going to keep them to include pharmacies that are serving neighborhoods that are already pharmacy deserts or the pharmacies at risk for closing. So how can Part D, I mentioned this already a bit, Part D policy changes address structural barriers and disparities in accessing and adhering to medications while ensuring equitable pharmacy reimbursement rates for Part D prescriptions, especially in pharmacy desert neighborhoods, mandate preferred status for pharmacies at risk for closure, especially independents serving these low access neighborhoods, and then mandate participating plans and PBMs to meet convenient pharmacy access standards for preferred pharmacies. Currently, they don't have to meet convenient access standards for preferred pharmacies, but they have to meet them for any in-network pharmacy. And there's a huge difference between a preferred pharmacy and in terms of affordability and a non-preferred pharmacy. And also whether or not a pharmacy is preferred or not contributes to closures, right? So you kind of really have to address these policy changes concurrently and not in isolation to really have an impact. And I think the biggest change that we need to do, not just for Part D, but for Medicaid and even commercial insurance more generally, is to strengthen the regulation of PBMs. And I think that's where a lot of attention is, especially around reimbursement and higher copays for patients and the lack of transparency in those. All right, I'm just going to spend the next kind of 10 minutes talking about state policies, especially those that I've worked on, but also just thinking about state policy in general, like how can state policies contribute to disparities in medication adherence or medication access? Well, I think for one, it's pharmacist prescribing policies, right? Which are growing and they're important, and they've been a key effort to kind of expand access, assuming that pharmacies are implementing these policies and people have access to pharmacies implementing these policies. And those that do implement them are implementing them equitably. The other is kind of Medicaid policies, whether there's coverage restrictions, different reimbursements, or even, critical access pharmacy payment programs that have been implemented in a few states. And how could they worsen disparities in medication adherence? Well, the idea is that they're going to increase prescribing, but if there are fewer pharmacies offering, and this is just an example of the pharmacist prescribing, if there are fewer pharmacies prescribing or implementing pharmacist prescribing services, then you're going to have fewer pharmacies that are in these neighborhoods providing the service that a policy was intended to provide, right? And you'll have fewer people in need that are prescribed these medications in the pharmacies located in or serving their neighborhoods. And the assumption is that these pharmacies are actually stocking or dispensing these products, whether it's contraception or naloxone or buprenorphine. I think people don't realize that many pharmacies don't have to stock everything. There's a few states that have dispensing mandates, but most states don't. And they're usually just for a few select medications, and they're often contraceptives. And Philadelphia, I think, is the only city that has a dispensing mandate. Before naloxone became over the counter, had a dispensing mandate, and still does for naloxone, Narcan specifically, which requires pharmacies to carry it and give it to anyone that asks for it. And if they don't, they're penalized. And after 3 penalties, I think they get their license suspended or something. But it's kind of these policies that could lead to fewer people in these neighborhoods getting medications they need, which could worsen disparities in medication use. One of the first policies we looked at was California's pharmacist prescribing expand prescriptive authority for contraception, for self-administered contraception. And we also looked at the availability of over-the-counter Plan-B, if pharmacies carry it and if they give it to patients. And what we found was that, first of all, only 10%, a year after this policy was implemented in 2017, only 10% of pharmacies actually provided the service. And this is looking at a census of pharmacies in LA County. So over 1,482 specifically, pharmacies. We did a mystery shopper study design, and we found that very few pharmacies actually implemented pharmacist prescribed contraception. I think it's closer to 20% now, but it's still very, very low. And only 3/4 of pharmacies carried over-the-counter emergency contraception. So whether it's they carried it behind the counter or in the store somewhere, only 3/4 did. There were differences by pharmacy type, but what was most interesting is that there were differences by neighborhood characteristics, where fewer Black or Latinx neighborhoods in LA had pharmacies that offered pharmacist prescribed contraception, but more pharmacies offered over-the-counter emergency contraception. And neighborhoods with very high teen birth rates, which are probably most in need of this service, especially in LA, only 8% offered pharmacist prescribed contraceptive services compared to over 11% of other pharmacies serving neighborhoods that didn't have high teen birth rates. And this is kind of just depicting, I think maps are really important, especially for targeting interventions. And, what we found was not only are there pharmacy deserts in LA that disproportionately affect South Central LA, which is largely Latinx, with some majority of Black neighborhoods that are high with to have very high teen birth rate. This is SPA 6. But the pharmacies that are there are less likely to implement a policy, a law that allows them to provide contraception without a prescription to patients that come in. And we also found, and I don't talk about this here, that they're still asking, the majority, I think it was 3/4, are asking for IDs when they don't have to ask for IDs. It's not required. So there's still more barriers to, and they have age restrictions when there shouldn't be age restrictions, even for Plan B. So, we have these policies where you make something over the counter, including naloxone. And the assumption is that it's going to be accessible, but also that it's going to be affordable. And I don't talk about the affordability aspect here, but that's an important aspect too, especially when we're talking about access, right? So the naloxone becoming over the counter, Plan B becoming over the counter, isn't necessarily improving access to low-income individuals, right, that can't afford to pay $50 for a unit, for a dose. So these policies could worsen disparities, given that we know poverty levels are higher in Black and Latinx populations than they are in other populations. This other, I recently looked at another policy in California that started in California in 2019, which is pharmacist prescribed PrEP services. And what we found was that very few pharmacies actually that provided the service across California. Less than 4% of neighborhoods overall had a pharmacy that offered this service across the entire state, had at least one pharmacy. And that encompassed only 18 of the 58 counties in California. And then when we did a mystery shopper survey, and this is still under review in LA County, we not only found that less than 3% of pharmacies offered pharmacist prescribed PrEP, which is used for HIV prevention, but no pharmacies in Black neighborhoods with unmet PrEP need offered the service, and only 22% of LA County pharmacies actually had PrEP in stock. So not only are Black and Latinx neighborhoods less likely to have access to pharmacies, but the pharmacies they do have access to often aren't providing the services that are offered in other neighborhoods, even if these Black or Latinx neighborhoods may need them more. And many of them don't carry the medications that they should be carrying to adequately serve the needs of the local population. This really is kind of the end of my presentation, but just kind of to summarize, right? There are structural barriers, and they operate in different ways through federal and state policies as it relates to pharmacy access, medication availability, pharmacist prescribing, and how that impacts populations. And the big assumption here is that people could mostly get their medications. I think it's at least 90% of prescriptions filled in the US are filled at a retail pharmacy. And the majority of people fill at least one prescription, especially older adults. I think all of them fill at least one prescription in a given 3-month period at a retail pharmacy. So the fact that there are policies, whether they're at the federal level through CMS or other public policies that are implemented at the congressional level, or state policies, whether it's PBM or the lack of PBM policies, or pharmacist prescriptive authority policies, or Medicaid coverage reimbursement policies, they're contributing to worsened access to medications because of these pathways, right? Whether it's pharmacy closures or kind of the inequitable implementation of pharmacist prescribing, where more pharmacies in more privileged neighborhoods are getting access, even though now it's more convenient. It wasn't like a barrier before, as much as it was in neighborhoods that don't have these services available to them, even though pharmacies can provide those services like pharmacist prescribing contraception or PrEP. And so, I really advocate for changes at the policy level to address these kind of persistent disparities we see in medication use. And I think the first step is to really develop that evidence base, not just to demonstrate pharmacy closures are a problem, but that they contribute to worsening disparities in medication adherence. Thank you.